Meeting last week because my grandma had a colonoscopy and they found colon cancer. So they're currently at the oncologist at this exact moment. So neither of them could be here with me.
Okay.
So they helped come up with questions, but of course want to be able to listen and hear what you have to say, and are sad they can't be here. But yes, of course, in the moment, I probably won't remember everything either.
So now, where are you standing with the pain program?
They have me set to start on the 14th.
Of April.
16th or whatever,
Okay, good. Beautiful. And yeah, you'll do the intensive reconditioning group. They have you doing that, like 4 days a week or something. And then in the meanwhile, you are doing the biofeedback. Is that correct?
I had another one this morning, and then I have another one on Monday.
Okay. Well, really do that. All the help, you can get from different angles is a good thing.
I'm trying everything I can.
It's great.
Yeah.
So now I did read, yes, the distraction is better. You also kind of gave a few other parts to that story that if it's not there, then it almost feels worse.
Right, so I don't know, I don't think it's I don't know the ultimate goal of the device, right?
It's to reduce it.
So
it's to reduce it when you don't have it on also. So it's a form of neuromodulation, which is what a spinal cord stimulator is doing, or the occipital stimulator, or supraorbital stimulator, basically peripheral stimulators, is trying to modulate the pain, reduce the pain, even past when you're using the stimulator.
So that's where I'm not sure.
Yeah, so the goal is not to have you walking around with a cephaly programmer glued to your forehead.
Okay.
Nonetheless, at least for the interim, using it, and then they also say that with the program that it's a good 6-week program of stimulation, and that over time the goal is to have you improve so that you're not needing to wear it all the time.
Okay.
So then I think the last thing you'd written to me is sort of talking about kind of what's next.
Yeah.
Except that, no. Okay. So we can do what's next, in the plan, but you do have the program you're going to be doing and the biofeedback, and you're finishing this.
I guess my understanding was coming in to talk about an implant.
Right. So the implant, just to refresh what we talked about before, it's basically stimulators going across the head. You're both sides. Mm-hmm. The headache is both sides and the front.
And sides.
Right, but that would be captured by the supraorbital nerve going here and going up, and we put them under the skin over the distribution of the supraorbital nerve.
Okay. So where do you go in?
I go in here from the side.
Okay.
For the trial. And then you just tunnel underneath, give you anesthesia so you're asleep for that period of time. Mm-hmm. And then here on the side of the temple, they will be poking out, and they'll be sutured in, and then gauze and tape and that sort of thing to then have it down externally, usually on the chest area here.
Okay.
And then you have that stimulator going for 7 to 10 days.
Okay.
So it's a 7 to 10 day trial period where, how does it feel?
Right.
It could be that after you put it in, it gets, better over time, but it wouldn't get better over time if you don't get any benefit. You need to get some benefit. We like to see 50% better.
Okay.
And then that 50% better can be, lots of different things. It can be less frequency, less intensity, overall averages are 50% better. Maybe pain's gone half the day. So you would have to see your results. But you know it when you see it.
Right. So what do those 7 days look like? Do I feel the thing going all the time?
Buzzing. Well, you could turn it off.
Okay.
So it's
this is an hour at a time, and then when I want to, I hit
off.
power.
No, this is a stimulator that's going all the time. You get to control it. So if it's bothering you, you could turn it off, for example. So Then there's different programs that they'll give you. There's 8 contacts on each side, and they'll be giving you different programs to try and different intensities that you'll be able to turn it up and down. So like, can you feel it? Is it too strong? Is it not strong enough? And so the company, which would be Medtronics, will be working with you to get that as perfect as possible. And then after 10 days or so, we then pull it out. It slides out really easily.
Okay.
And then make a decision, was it fantastic or not, and then go for an implant.
Okay.
And then the implant is going here, and then tunneling in the neck, and then putting the little battery here. And here is the approximate size of the battery.
And would I, like, be able to, would it protrude, kind of?
Depends on how much padding you have there. So if you have a fair amount of padding, it won't. If you're super skinny or become super skinny, then it would protrude. So, they try to put it about right here. And I do the trial, but the implant's done by the neurosurgeons I work with. Try to put it about here. You need to charge it maybe once a week or so, depending on the energy requirements that you use.
How do you charge it?
Through the skin. So you put they give a wand that goes over it. And that part of it, the mechanics of it, I'm not exactly sure. I know it for the low back, you wear like a strap around, but how you would do it here, it might be that you tape the charger over it.
Okay.
And then it charges through the skin and charges the battery up. You could do a non-chargeable one that just sits there, but the battery has to be bigger, and then that's like that. And I really don't recommend that.
Oh, yeah. That's big.
That's big. So you really don't want to have that size battery.
Right. So
you want more of the poker chip battery that goes in.
And how does that battery affect me in a daily life? Airports or security?
Going through airports, you'll buzz. So you get a card, a medical card,
mm-hmm.
and the airports are very familiar. Normal, high-use airports are very familiar with people having hip replacements and shoulders and pacemakers. This is similar to a pacemaker, so you would just notify them, and then you have to be wanded.
Mm-hmm. Okay.
I mean, don't hold me to that.
No,
That's
right.
my understanding.
Right. Okay.
So affect your daily life, it wouldn't really affect it except for the fact that you have an implant. So it could be sore here for a couple months. Generally that gets better. And then these leads, risk of anything is infection, bleeding. That's really rare in the scalp because it's so vascular that infection risk is quite low. But the lead can poke the skin and then need to be revised. The leads can move, need to be revised. It could be that, that the leads don't go in as nicely and close to the nerve, and you might get some muscle contraction. So things like that can occur with the implant.
Okay.
And then in general, you only do this kind of thing when everything else has been tried because you're young and putting in an implant. So it's like medications and injections and the program and biofeedback and acupuncture. And you're doing that. You've done that and you're doing that. So we're just wanting to make sure that we move along, making sure you're doing all the steps along the way.
Do you feel like we're there?
You're getting there.
So you don't feel like we're there yet?
Oh, well, you kind of haven't finished the program or been in the program or the biofeedback.
So you would want me to finish that month? Or
is it 1 month, 5 weeks?
The 5 weeks of that.
See, that's right around the corner. So you wouldn't even, I don't have surgery time till May. And so that works out really well. And you'll learn, it's not that they're going to cure your headache in there.
Right.
But you will learn, other strategies. Can I just take this really quick? Dr. Cherry. Yes.
Your attention, please. This is a test of the overhead page system. This is a test of the overhead page system. This is a test of the overhead page system.
Sorry, go ahead.
No, it's okay.
Other questions?
So what is this thing actually called?
Well, it's a stimulator. With what most people will call them is spinal cord stimulators, because it's FDA approved for use in the spinal column. But we use them instead in either occipital placement or supraorbital placement for headache. And so in your case, we would call it a supraorbital stimulator. You could also call it a peripheral nerve stimulator.
Because I was watching The Good Doctor last week, and I think they were doing the same procedure on the guy, and I was like, oh my gosh, that's what they were talking about. But
it was classically done as occipital stimulation, but what we found, and we've done a lot of stimulators for headache, the severe refractory headaches, is that if you really have a frontal headache and you put an occipital stimulator in, you don't get the nerves in the front. So a supraorbital stimulator is more appropriate in your case.
Okay. So is your typical person that gets this because of migraines?
Migraines, but then it's really migraine reformed, because a classic migraine is not a chronic daily headache. So really we're getting the patients that have transformed whatever headache they have to chronic daily headache.
Okay. Because I'm struggling with having that LP and her saying, I don't have IIH anymore, and I'm now up to 5 of the trazodone a day, and I still don't have any relief, and I don't even know what it feels like to be pain-free, and right. I'm just miserable all the time, and I don't know what, everyone's like, well, what's wrong with you, or what's the diagnosis, or does this thing even help? And it's like, well, it doesn't help, but it's a distraction, and it helps me not think about how much pain I'm in.
Right.
But do you want an implant if that's not even helping? And I don't know anymore.
Well, I don't have an answer for, I have an answer that you can try a stimulator and see how it helps.
But I like the trial.
But it is an implant, so we really like patients to have done medications first, because that's the classic thing to do is medications.
But I feel like I've tried a ton of medications.
Well, except for the Topamax.
How much would you want me to go up to?
I'm going to leave that to Kreisman. Kreisman's going to titrate you up. And I know you were going slow, which...
Well, I think she said up to 7. I'm already up to 5.
Right, so you're getting there.
Yeah. And if you wouldn't do this till May, I would definitely be there before that. That's only 2 more weeks.
And so the Topamax is not helping.
No.
And then do continue with her about any other medications, and I'll write to her like what other things are going to be tried. Because if you can find a great medication, that's fantastic.
Right. I mean, I'm willing to do anything.
Right.
And I don't want to feel like I'm jumping to this, but I want to jump if there is a chance to do something that will help.
Right. I agree. I understand.
Yeah.
And we did Botox, no benefit, supraorbital occipital nerve block,
yeah, we did
no
the
benefit.
blocks, we did the DHE, we did the lidocaine.
Yeah, and the hypertension is normalized on your medications, and then I don't know if they are stopping that medication now. The Diamox, are you still taking the Diamox?
No, I'm not taking the Diamox.
So you're not taking the Diamox, so that is resolved. Not taking it. Oh, let's see what else, and then. Did we do a sphenopalatine ganglion block through the nose?
No.
There's a nerve block through the nose called the sphenopalatine ganglion. It's the back of the nose, so it's a facial block.
Uh-huh.
And that can help headache, migraine. It helps with cluster headache classically.
Mm-hmm.
But then we are doing it for migraine. So you would be a candidate at this point for that. All right, I like that. I like that idea. Thing is that we should actually do the Topamax. Let me ask Dr. Kreisman about that and where we can fit in sphenopalatine ganglion block series.
Okay.
And there's different ways of doing it, but the easiest way is to do a little spray at the nose, and then it's sprayed, the local sprays to the back of the nose, or I can do them here, and then after that you're able to do it actually at home. You do a series, every day for a week, and then it's every day for 2 weeks actually, and then for a week, and then basically like 3 times a week. That's another idea that we could do. All right, so let me let Dr. Kreisman know that, because I can't interfere with her cycle. Like if I do something and then it's like, oh yeah, the Topamax is working, but just like, well, no, it's really not. So the Topamax you'll have at 2 weeks, then you could stay on that, and we could do the sphenopalatine ganglion blocks. And once again, you are living in San Francisco, right?
Daly City, but yeah, right here.
Okay. All right. All right. I'll work with her on when I could schedule that.
Okay.
And then I want to make it easiest for you with all your driving and appointments and that kind of thing.
Well, if I'm going to be here 4 days a week in April.
And I can talk with Dr. Michelozzi if he does that, because he's down in the French campus.
Right, so I'm going to be down the street.
Right.
Almost every day anyway.
Okay. So that's kind of it from my standpoint, is sphenopalatine ganglion blocks that we didn't do. We could do that. And then there's the trial and putting that on the books, making sure that medications are complete. You could do the trial before you did another set of medication trials, too.
Okay. So is it possible to put the trial on a calendar before we keep getting pushed out?
Yeah. You can do that.
Okay.
So that would be like May or June.
Okay.
Sound good?
Yeah.
Beautiful. And that would be, you're in Daly City, so Redwood City is pretty close for you, too.
Mm-hmm.
All right?
Okay, so do I ask them out?
No. It's all out of Redwood City. So I have the scheduler there do it.
Okay. So she'll call me?
Uh-huh.
Okay. So yeah, really the trial answers a lot of the questions, because that is the best way to know whether it would work. And
right. You do the trial. The beauty of this is that you get to have a trial.
Okay.
And see whether or not it's helping.
Right.
So you don't have to jump into something that's like, well, I have no idea if it's going to help.
Permanent. We really would get all the answers from.
So that's really a nice system that you get. And it is stronger than your cephaly.
Yeah.
Because it's right on the nerve.
Right on there. Okay.
So the cephaly is great if it works, because it's not an implant, but if it's not helping long term. But I can see you've definitely giving it a college try, because you've got it pinned to your forehead right now.
Yeah. I get asked if it's flashlight almost every day, but I don't care.
So it doesn't stick, or it is sticky, but
it's like kind of sticky, but also this thing is just really awkwardly heavy on the top part, so it like detaches very easily. So the cephaly divide, so it's like sticky, but not sticky enough.
Right. It looks good with the little bandana, too.
Yeah.
I like it.
Whatever. So this just helps hold it on, and I don't have to like sit here and hold this to my face.
Right.
So, whatever.
But now that I get to see this headgear you've set up, I can tell other patients.
I mean, it was like $2 at Walgreens. So, yeah. It works.
Okay, so does that sound good?
Yeah.
I'll communicate with Dr. Kreisman.
Okay. Awesome. And would Kreisman be the one to do the implant if we got there? Okay.
Dr. Pazeshkian or Dr. Sedrak.
Okay.
The neurosurgeon. I'll do the trial.
Out of Redwood City?
Yeah.
Okay. Okay.